Dr. Hammack is a neuro-oncologist. She spent over 20 years at Mayo Clinic in Rochester. She's now at Mayo Clinic in Jacksonville. So Dr. Hammack's going to be sharing with us management of spinal disease and metastases.
So today I'm going to, first of all, no disclosures. I'm going to talk about metastatic spine disease, and most of my talk is going to focus on epidural spinal cord compression, although I will say a few words about leptomeningeal spread of tumor if time allows. So I'm going to talk about the differential diagnosis of spine disease in patients with cancer, again focusing primarily on epidural spinal cord disease related to vertebral metastases. I'm going to talk about the clinical presentation of epidural spinal cord compression and the diagnostic approach to that disorder, and finally the therapy, both supportive care as well as the evolving role of surgery and radiation. Okay, so first of all, obviously in a patient who has cancer and new onset back pain, it's very important to rule out metastatic disease before anything else, although more things than metastatic disease can cause spine pain in patients with cancer. For instance, therapeutic modalities can cause back pain or spine disease. Radiation myelopathy occurs in maybe about 1% of patients who receive radiation therapy to the spinal cord or adjacent structures. Some chemotherapies can injure the spinal cord, particularly intrathecally administered or intra-CSF administered drugs like methotrexate and thiotepa and cytarabine. Also systemic therapy, particularly the platins, can cause spinal cord disease. And of course, patients can get spine problems unrelated to their malignancy, like spondylotic myelopathy and trauma and demyelinating disease, et cetera. Although, again, I think the index of suspicion should be very high that someone has metastatic cause for their back pain, particularly if they already have a diagnosis of cancer. So as far as tumor-related causes of myelopathy or spine disease in patients with cancer, epidural spinal cord compression is the most common. Leptomeningeal disease, intramedullary spinal cord metastases are much rarer, and paraneoplastic myelopathy, although it is an entity, is extremely rare. In the 30 years that I've been a neuro-oncologist, I can say that I've seen about 3 cases. So it's quite unusual, but still it's a potential etiology. So in terms of frequency, now about 20% of patients will get metastatic disease to the vertebra. It's very common, and patients with any form of cancer can get metastases to the vertebra.